Welcome to the YouTube revision series on biostatistics for MRCOG2 on certain high-yield topics. I am Dr. Avinash SS, one of the mentors at StudyMEDIC Academy group, and today we will be listening to revision series on some of the high-yield topics. Now, which are these high-yield topics that we will be discussing? See, the high-yield topics in MRCOG2 includes, of course, hypothesis testing, doing the inferential statistical tests, study designs, effect estimates, and diagnostic accuracy tests. Of course, there are other small topics which are also present, which can be asked. But for today's revision series, we shall be discussing the below. So coming to the first topic, that is the hypothesis testing. Now, what is an alternative hypothesis other than scientific hypothesis? Is the hypothesis that we make before we do the study based on the biological plausible explanation. Now, what is this null hypothesis? Null hypothesis is actually opposite to this alternative scientific hypothesis. It is always stating the null. For example, if anemia causes postpartum hemorrhage is an hypothesis, the null hypothesis states anemia has no effect on postpartum hemorrhage. So that's one example. Now, some of the questions that are asked is regarding the errors in hypothesis testing. Now, what are those errors? Now, when the null hypothesis is false, okay, and our study also rejects the null hypothesis, then it is called as a true positive finding, also called as the power. It should be ideally be more than actually 0.8 or 80% in a study. However, when the null hypothesis is false, yet our study rejects the null hypothesis, does not reject the null hypothesis, but accepts the null hypothesis and gives a false positive finding. That is, here null hypothesis is rejected when true. You can see the null hypothesis is true, yet instead of not rejecting it, we are rejecting it. Then it is called as the false positive finding or the type 1 or alpha error. It should be less than 0.5. Now, what are the other errors? You can see here, when the null hypothesis is true and we correctly accept it, that means we don't reject it in our finding, then it is called as true negative or confidence in our study, which is usually should be more than 0.95. When the null hypothesis is false, we should have rejected this null hypothesis in our study. Instead, we are not rejecting or accepting it. That is, null hypothesis is accepted even when false. Then it is called as a false negative finding. We are giving a false negative finding. And this is also called as the type 2 error or beta error. This should be less than 20%. Usually, power and that is the true positive plus false negative is always equal to 100%, that is 1, using which we can either calculate power given error or beta error given the power. Now, p-value is the probability that the null hypothesis, assuming that the null hypothesis is true, the probability that whatever we are observing in a study is a random effect. If it is less than 0.05, then it may not, the probability that it is a random effect is less than 5%, and we can conclude our finding as significant. Similarly, when less than 0.1 as highly significant and less than 0.01 as very highly significant. For a detailed explanation, please subscribe to our StudyMEDIC group for free access to the library podcast video. Next, we will come to inferential tests. Now these are the tests that are used to test our hypothesis, and we get a p-value here. Now there are what are called as the parametric tests, means those tests we use when all the assumptions are met, that is usually when the population is normally distributed. And there are non-parametric tests that are used when the population is not parametrically not normally distributed, or assumptions are not met, or the tests which will deal with the categorical data are all non-parametric in nature. Now, for example, if we have to see, if you want to find out if there is a difference, okay, between the mean birth weight, which is a continuous variable, mean birth weight, which is a continuous variable, of a particular sample of, let us say, pregnant woman, and that of the known specified population, that mean birth weight. That means we already know mean birth weight of a whole population. We want to compare our sample mean birth weight with that, and see if our sample mean birth weight of this our population is very different from the known population from which this sample is drawn. That means here we are only having one group. In such a case, if you want to test the significance of difference between mean of one group with the known group, and this is normally distributed, this mean is normally this birth weight is normally distributed, we use what is called as the one sample t-test. Now if it is not normally distributed, the parametric equivalent is one sample Wilcoxon sign rank test. Now looking at the other scenario, see the other scenario here. Now here we are trying to find out, is there a significant difference, significant difference between the mean birth weight, which is a continuous variable birth weight, of the sample from a healthy woman, which is group 1, versus anemic women who are anemic. This is what we want to find out. Now here again, birth weight is a continuous variable. If it is birth weight is significantly different between two groups, that is what we want to find out. Now these two groups, healthy women and anemic group, they are independent of each other. They are mutually exclusive groups. They are not related. They are unpaired groups. In such a case, we use, if the birth weight is normal distributed, we use what is called as the unpaired t-test, also called as the independent t-test, also called as the two sample t-test. When the assumptions are not met and the population is not normal distributed, the non-parametric equivalent is the Mann-Whitney U-test. Now look at this scenario. Here we are trying to find out, is there a significant difference between the birth weight of, which is a continuous variable, sample from healthy women, which is group 1, anemic women, which is group 2, and PAH women with PAH, group 3. I think here there are more than two independent, mutually exclusive, unrelated groups, categorical groups, and we want to find out the difference in this continuous variable, whether in this more than two groups it is different or not. And if it meets all the assumptions and it is normally distributed, then we use one-way ANOVA test to do this inferential test. The non-parametric equivalent is Kruskal-Wallis test. Non-parametric equivalent is the Kruskal-Wallis test. Now coming to another scenario, you can see here we want to find out, is there a significant difference between the hemoglobin, which is a continuous variable, before giving treatment and after giving treatment. You can see here there are two groups, but these two groups are all not mutually exclusive. That means they are paired or related groups. And when this continuous variable hemoglobin is normally distributed, and we want to find out if the mean difference, is there a significant difference between the mean of this continuous variable between the two related groups, then we use paired t-test, and it is normally distributed. Parametric equivalent is paired t-test, and it is not normally distributed. The non-parametric equivalent is the Wilcoxon sign rank test. Now, when do we use McNamara test? we usually use McNamara test if you want to find out is there a difference in nominal variable, that is here you can see difference in anemic status between two groups, two related groups. You want to know more about this McNamara test and other further details, please subscribe to StudyMEDIC for accessing to our library. Now look at this scenario, third scenario. Here we are trying to find out is there a significant difference in anemic status, whether anemia is present or not, which is a categorical variable, right? Then we have what percentage of people are having anemia in this group and not having anemia in spontaneous vaginal delivery group. Then how many percentage of women are having anemia in that is categorically in LSCS group, etc. That we want to find out is there a difference in this proportion, right? And of the categorical variable, and these two groups are unrelated. Then we use what is called as the chi-square test. Chi-square test. So usually we do chi-square test to find out association between two categorical variables, or to find out if one categorical variable is independent of the other. One categorical variable is the independent of the other, or if the observed frequency of this, whether anemia is present or not, is different from the expected frequency in these two categorical groups. So here we are trying to find out whether anemic status is associated with if the delivery happens to be spontaneous vaginal or LSCS, or is it independent of this type of delivery is independent of this anemic status or not. So in such cases, to find out the association between two categorical variables, we use chi-square test. Now in this scenario, here we are trying to find out is there a significant association or relationship, if at all, what is the strength and direction between the birth weight, which is continuous variable, and HB level, which is also another continuous variable. So when we want to find out the association between two continuous variables, and these two continuous variables are normally distributed, then we use Pearson's correlation test, a parametric test. And when it is not normally distributed, or if one of the variable is an ordinal variable, then we use an alternative non-parametric equivalent called as the Spearman correlation test. Now, if we want to quantify this association, or if you want to predict one variable, dependent variable from the independent variable, or if you want to find out the effect of one variable on the other, then we go ahead and do what is called as regression. Now look at this scenario. Here they are trying to find out if there is an effect of hemoglobin level, which is an independent predictor variable, a continuous variable. Does this hemoglobin level affect the birth weight, which is now birth weight is the dependent variable, which is also continuous variable. Now both these are normally distributed. Now here we are trying to predict or quantify the change in birth weight based on the change in hemoglobin levels. In such a case, we do what is called as the simple linear regression. Now look at this scenario, same extended scenario. Here we are trying to find out the effect of not only hemoglobin but also age, whether pH is present or not, etc., which are all more than one independent variables or predictor variables on what? Birth weight, which is one dependent continuous variable. So dependent variable here is continuous, but the multiple independent variables are there. Then we go ahead and do what is called as the multiple linear regression test. Now when do we do logistic regression test? Observe this scenario. If there is an effect of hemoglobin level, right, which is an independent predictor variable, it can be continuous or whatever it is, on pregnancy outcome, the dependent variable here is categorical. When the dependent variable is categorical and we want to predict this categorical variable from other independent variables, then or quantify that, then we use what is called as the logistic regression. So to find the strength and direction of the association between two continuous variables, we use Pearson correlation. Alternative is the Spearman correlation. To find or predict the effect of one continuous variable on the other, simple linear regression. To find the multiple independent predictor variables effect on the continuous variable, multiple linear regression. To find the effect of predictor variables on the categorical variable is logistic regression. Also subscribe for detailed scenario-based analysis to our StudyMEDIC group to learn more about the inferential test preparatory videos. Now coming to study design. Now there are many study designs. Based on whether the study design has an intervention, it is called as interventional or experimental study design. If no, it is called as the observational study design. Amongst the observational study design, some observational study designs have control group, some don't. When they don't have the control group, they are called as the descriptive study designs. Descriptive observational study designs. One of the classical example is the cross-sectional survey. When they do have the control group, observational study designs have control group, they are called as the analytical observational study designs. We will discuss that later. Now observe here. In women who are attending antenatal clinic, the data on many demographics like age, BP, weight, knowledge, or any knowledge of danger signs were all collected. Now here, what is happening? At a single point in time, the data is collected either by interview or questionnaire. Here it is, we are trying to find out the characteristics of the demographics, a distribution of this age, BP, etc., and what is the prevalence of hypertension, etc. at a single point in time. Then such are called as cross-sectional surveys. Now observe the second scenario. Here, in women who are attending the ANC in a tertiary hospital, that means in a particular locality, that here a case group, hospital case group it is called as, okay. On age, BP, hemoglobin, weight, knowledge of danger signs collected. Now it is again compared with another ANC in a village. Here what is happening? The same cross-sectional study is done in one particular locality, and another cross-sectional study is done in another particular locality. We are comparing those demographics and characteristics and distribution and prevalence between these two. That means it has a control group. This is a cross-sectional survey which is having a control group. So it is analytical cross-sectional survey with control. Analytical cross-sectional study design with control. Here these are the two control groups. Now what is case control study? Look at the scenario. Here data on so many, maternal obesity, whether they were smoking since long, how much they were smoking, they were all elicited by using a questionnaire or an interview. In women who were having either neural tube defect or another case of congenital heart disease, and the same data were elicited in those which are not having this rare cases. So they first selected using a diagnostic criteria in a particular hospital or a setup who had neural tube defect or congenital heart disease and who did not have. And then they matched these controls who did not have this rare case but have other diseases also with respect to age, gender, etc. Then they asked the questions of all this, the previous history, if they are obese, if they are smoking, etc. Then they calculated the odds of exposure in case versus odds of exposure in the controls to find out the odds. So here the association can be found, but the causation cannot be found because here there is no follow-up and incidence cannot be found. So temporality of causation cannot be established. So such study is called as the case control study, where from the rare case and rare without the rare case, we elicit the history of exposure and compare the odds of exposure in those with case and without case. That is called as a case control study. Now coming to other type of studies. Other type of descriptive analytical observational studies other than the case control study is also a prospective cohort study. Now look at this scenario. Women with different lifestyle were followed up, means they were chosen. Women having a good lifestyle or a bad lifestyle, women who are smoking or not smoking, dietary lifestyle, etc. They were all chosen, means those with different exposures were chosen, and those who are exposed were followed up to see what is the pregnancy outcome in future. Those who are having a poor lifestyle, what is the pregnancy outcome, and it is good or bad. Those who are not having having a good lifestyle, what was the outcome? But was it good or bad? Right? So they follow them up in time, and they can find out the incidence. Since temporality of exposure can be and the outcome can be established, it can be used to find out the causation, and we can calculate the risk ratio. We can study this later. So this is called as a prospective cohort study design. It is a little bit expensive compared to the case control study design. However, to find out the causation and even to find out the adverse effect of the drugs already in the market, we can use this. The next one is the retrospective cohort study design. Now observe this scenario. Here data on maternal characteristics and obstetric characteristics, like which obstetric intervention were given, what was the maternal situation, they were all obtained from electronic medical records. They went back in time, looked at the records and obtained this data. Then using the data only, the record only, they saw how many of them in the next few months developed a good postpartum quality of life or had a poor postpartum quality of life, because they were all recorded into the electronic medical records. So they went back in time, used the records to come in front till they have outcome or not. So same here, they went back in time to find out who are having exposure, that is intervention, and what was the quality of life, and who are not having this whatever related intervention, and who are having a good quality of life, or what was the quality of life. Since they found out the incidence of poor quality of life in those with intervention and not intervention, to find out the causation. Because they went back and used the records, it is called as a retrospective cohort study design. Now coming to interventional studies, one of the interventional study where subjects are not allotted to interventional group and non-interventional group based on randomization. They are conveniently allotted. It is called as quasi-experimental or non-randomized interventional study. Here you can see nurses were conveniently allocated to antenatal care education program. One were allotted to one, and the others were not. Other people were not allotted to this program, and they were followed up to find whether there is an effect of this program on reducing anxiety during pregnancy. So the efficacy of intervention can be found out here. Such is called as the quasi-interventional study. Now, what is the difference? You can see this between this RCT. Here, nurses were randomly allocated to these educational programs, and then they were followed up to find the effect on reducing anxiety during pregnancy. Here, what happened was both the investigator and the participant knew that they were either allocated to education program or not. So it was the intervention was not blinded with respect to investigator and participant, and hence it is called as the open-ended randomized controlled trial. Why it is randomized? Because they were randomly allocated. And why it is a controlled trial? It is a interventional trial. So it is called as the open-ended random controlled trial. Now, what is a single-blinded randomized controlled trial? You can see that here, women were randomly allocated. It is a randomized allocation, so randomized controlled trial, to intrapartum music therapy, and then they were followed up to find the effect on reducing anxiety during the pregnancy. Now here, only the investigator knows what type of music therapy is given. However, the participant does not know whether they are given a music therapy interventional or not, which type of is given. So investigator is not blinded, but only the patient or participant is blinded. So it is called as a single blinded randomized clinical trial, controlled trial. Now, what is the double-blind RCT with intention to treat? Now, we can see here, women were randomly allocated to IV iron therapy and also a concealed placebo to find the effect on maternal and neonatal outcome. Now, here, they were randomly allocated. It's a randomized controlled trial. And both investigator and participants were blinded to whether they were giving IV iron or, because it's a concealed placebo, nobody knew what type of treatment is given to whom. And all those who were recruited were all used for analysis, including the last to follow up, everyone, or those who crossed over, or those did not comply, whoever was there, they were all used for analysis. And this type of study is called as double-blind RCT with intention to treat. Now look at the next scenario here. Here, the same allocation was done, same scenario, but however here, only who remained in the study at the end of the study were used for analysis. Means those who were last to follow up, non-compliant or crossover, they were all excluded from the study. And this type of study is double-blind RCT without intention to treat. Now coming to effect estimates. Now there are many effect estimates. One of the effect estimate is the odds ratio. Now here you can see smokers are associated with low birth weight and non-smokers whether they are associated with low birth weight. So what they happen here, the exposure data is taken and whether their outcome are seen, usually using a case control study. And you can see 75 smokers had a low birth weight and 100 of the smokers, those who smoke, had normal birth weight. And among non-smokers, 150 were have low birth weight and 300 had a normal birth weight. Now, to calculate odds ratio, it is nothing but the ratio of odds of exposure in case to odds of exposure in control, that is a unexposed. Okay. Now, what is the odds of exposure in case? It is 75F. Now, what is the odds of exposure in control? It is C by D, that is 150 by 300. The odds ratio is AD by BC, which is equal to 1.5. The meaning here is the odds of low birth weight in smokers is 1.5 times more compared to the odds of low birth weight in non-smokers. So the association is 1.5 times more. How much more than 50% more chance. So to find out the details about odds ratio, please subscribe to our StudyMEDIC. Now, so coming to the next effect estimate is the risk ratio or relative risk. Same example. Here relative risk is the incidence of exposure in case, not the odds, with respect to incidence of exposure in control, that is unexposed. Incidence in exposed ratio to incident in unexposed. Now what is this incidence? It is A by A plus B. That means the incidence 75, that is 75 out of 175. A by A plus B. Okay. It comes to around 1.43. Incidence in unexposed is C by C plus D, 150 by 450. So you can see the difference between odds and chance here. Denominator is having both possibilities. It's 0.3. So IE by U becomes this much. So what is the relative risk here? So the relative risk is a little more. That is more than 1 time. So the relative risk of low birth weight in smokers is 1.1 to 1.2 times more than the risk of low birth weight in non-smokers. Now, look at this scenario. What is if the intervention reduces the risk? If the intervention reduces the risk, we can find out absolute risk reduction using this formula, IE minus IU. Now, what is relative risk reduction? It is the reduction due to treatment compared to those who are not treated. It is used by the formula IE minus IU by IU. What is number needed to treat? How many needed to be treated for one to be benefited? It is used by the formula 1 by absolute risk reduction. Now, what is the meaning of all this? how we can communicate this to the patients, and how we can calculate all this. To know further details, please subscribe to our StudyMEDIC library and the groups. Now coming to the last topic, that is the diagnostic accuracy tests. Now this is the index test which is compared against the gold standard. The transvaginal ultrasonography used determines preterm. When it is positive, this many are preterm, true positive. When it is positive, this many are full term, so it is false positive. Ultrasonography findings are negative, but still preterm, false negative, but full term, true negative. So now we can see how to find out this. So what is sensitivity? You can see the up to down arrow here. Out of those who are having the outcome, how many are having the test positive? So 250 by 250 plus 150. That is called as a sensitivity. True positive by true positive plus false negative. So it is also called as the true positive rate. Now what is specificity? Look at the low to high arrow. Out of those who are not having the outcome, how many are tested negative? It is specificity, also called as true negative rate. It is used by the formula true negative by true negative plus false positive, that is 300 by 400. Now what are the positive predictive value and the negative predictive value? Look at the left to right arrow. Out of those who are tested positive, how many are having the disease outcome? It is positive predictive value. True positive by true positive plus false positive. Now what is the negative predictive value? Look at the right to left arrow. Out of those who are tested negative, how many are not having the outcome? That is true negative by true negative plus false negative. It is called as a negative predictive value. Now what are this likelihood ratio? It is used by positive likelihood ratio used by the calculation of this formula sensitivity by 1 minus specificity, and negative likelihood ratio is used by the formula 1 minus sensitivity by specificity. What are the differences between that? What are the advantages? How much it should be? What is the diagnostic accuracy if it is more? What is the relationship between prevalence and incidence and the sensitivity, specificity, and positive and negative predictive value? For all those details, subscribe to our StudyMEDIC group. So we discussed the hypothesis testing, inferential tests, and then we discussed the study designs, effect estimates, and also diagnostic accuracy test. For further detailed explanations, if you require, you can see you should subscribe to our StudyMEDIC StudyMRCOG library, wherein we have all podcasts which you can listen to, preparatory videos based on individual topics, detailed explanations given you can listen to and watch, and also detailed session recordings are available. You will get a free access to mock papers and recall papers which you can solve at any point in time. You can see we all have other various national and international courses for which you can subscribe, and you can contact on these following numbers. So hope this YouTube revision series was helpful for your problem solving. Thank you from Dr. Avinash. Have a best of luck.